And you should have received a notification. Good.
Yep.
Yep.
All right, 1 o'clock. Let me know. Ready? Okay.
Sure.
Welcome to PACES, or Pediatric Acute Care Education Sessions. We have a few people still joining us, but we'll go ahead and get started. Today, we're going to be talking about improving the acute care for our LGBTQIA plus youth. My name is Heather McKnight. My pronouns are she, her, and I'm the Director of Pediatric Hospital Medicine at UC Davis.
And I'm Leah Zimanatis. My pronouns are also she, her, and I am the Chief of Pediatric Emergency Medicine here at UC Davis. We don't have any financial disclosures to present today, but the session that you're participating in is going to be recorded for use as enduring CME. So by continuing your participation in the session, you're providing your consent for this recording.
Before we get started, I wanted to acknowledge QPHM, which stands for Queer Pediatric Hospital Medicine. That's a subcommittee for the American Academy of Pediatrics section on hospital medicine. And a lot of the content that we are sharing today was initially made in collaboration with that group. In addition to that, I just wanted to kind of set the stage for our session today. We want to make sure today that we maintain a really safe environment for everybody to learn. And so what we would ask is that if people ask questions or share, that we assume the best intention and that people are in the space to learn. And in addition, just keep this as a healthy, growing learning space for everybody.
And then we will have a time at the end of the session where the recording will be turned off. So if there are questions that you want to ask outside of that recording time, feel free to save them for then. So some of our objectives for the coming session, what we'd like to do is provide some background on why an LGBTQ plus affirming environment in the healthcare setting is so important, and talk about some of the disparities that we hope to mitigate. We want to identify some key steps to creating an affirming acute care environment. And then, because things don't always go as smoothly as we hope, we also want to review a method to navigate some mishandled clinical encounters. And then wrapping up, we want to offer some concrete goals that we all can incorporate in incorporate affirming practices into our healthcare setting. So some things that we can work on as we move forward from this session. So first off, we're going to spend some time discussing why it's so important to create these affirming environments. So the first reason that comes up is that we will all be caring for sexual and gender minority youth. As I learned preparing for this session, it can be really challenging to accurately measure the LGBTQ plus population. Estimates of the size vary, and they really vary for a number of reasons. One of these includes some differences in the definition of each population that's studied. There's also some differences in the way that the surveys are administered and the survey methods. So for instance, some surveys ask subjects to self-identify their sexual orientation, for instance, and others may ask about sexual experiences or sexual background or partners, and then label sexual orientation based on that. There's also tends to be a lack of consistent questions asked by particular surveys over time, so longitudinal data is particularly challenging. The data on this slide is a 2020 estimate of the LGBT population. And this data was extrapolated from 2015 and 2017 youth risk behavior surveillance surveys. It was compiled by the Williams Institute at UCLA. And this source suggests that nearly 2 million LGBT youth are present across the United States. And when you look at this, it estimates it's about 9.5% of the total population of youth in the US between 13 and 17 years old. Affirming environments also matter because gender diverse youth participate in the healthcare system in numerous ways. And this includes for many, many issues that have nothing to do with their gender identity or their sexual orientation. We want to remember that these are kids with typical pediatric issues, and ultimately we want to provide them with a safe space for all types of their care and help them build trust for the medical community.
Now we want to get into a little bit more detail of some of the other reasons that our LGBTQ youth may be seeking out healthcare and look a little bit more closely at some of the health disparities that this youth population faces. If you look across this slide, some of the health disparities for this population include depression, anxiety, suicidality, being subjects to violence, increased risk of substance use, high-risk sexual behaviors, and disordered eating, which all affect a child's overall health. And so for this population, there's an increased need for medical services in outpatient, emergency department, and inpatient settings due to these health disparities. In addition, there's a huge need for increase in research that help us address the drivers of these disparities. I think on a personal level, one of the things that I think this makes me reflect on is how are we identifying these risk factors for our youth? Are we educated ourselves and so that we can ask the questions to be able to get this information? And then are we educated on what to do with that information for the youth that present to us? So the first topic that we're going to go into a little more detail on is sexually transmitted infections or high-risk sex behaviors. Our sexual minority youth are at higher risk for HIV, sexually transmitted diseases, pregnancy, and all those related behaviors. And so being able to provide appropriate counseling and resources for our sexual and gender minority youth is critical in terms of improving their health and well-being. The next topic that we're going to focus on is thinking about obesity and disordered eating. Our LGBTQIA youth has a higher rate of disordered eating, and most specifically, we see that most prominently in our transgender boys. They have a lot of tie-in with body dissatisfaction or dysphoria, and so with this population, a lot of times they'll describe that they're trying to lose weight to maintain a more masculine appearance. And so found a lot more in our transgender boys than girls. In addition to that, this population also has a higher risk of being overweight or having obesity, leading to a decrease in their health and well-being as well. The next topic that I wanted to spend some time talking about is violence, and this is our transgender and LGBTQ youth being subjected to violence. Some of this data that I first wanted to present and go into a little more detail is a little bit older, but I think gives us a flavor of, what our youth are experiencing in the community. In 2016, 18.4% of all hate crimes in the US were attributed to being related to sexual identity and gender orientation bias. So if you think about that, 1 in 5 events being related to this. In 2018, sexual and gender minority adolescents reported themselves that 11% had had an experience of either having a sexual attack or rape. 77% reported that they had experienced unwanted sexual comments, verbal threats was 73%, and being bullied was 70%. And so I think, this really paints a picture of what the everyday experience can be for our LGBTQ youth. If you're wondering if that's gotten better with time, the Trevor Project did another survey in 2022, and in their report, they report that 36% of LGBTQ youth reported that they had either been physically threatened or harmed due to their sexual orientation or gender identity. One of the other things that I wanted to emphasize when we think about why this population may have a higher risk of violence and being physically injured is that this population also has a higher risk of being homeless, and homelessness is highly correlated with a higher risk of violence, as well as either participating in commercial sex work or what's called survival sex, in which LGBTQ youth exchange sex for money, material goods, or shelter. And so again, putting this population potentially at even higher risk for some of these problems. In addition to this, our LGBTQ youth are also overrepresented within the foster care system. This slide looks really busy, and it took me a little bit to absorb all this information, but this is looking at substance use in our sexual and gender minority youth. If we start from the very top, that first kind of dark greenish gray bar that shows 11% indicates that 11% of heterosexual youth reported that they had ever used illicit drugs. If you look at the bright green bar below that, 21% of youth who had identified as LGBTQ had reported that they had ever used illicit drugs. The two bars below that kind of get at what Leo was talking about, where you're changing from how do you self-identify to what are your actual reported behaviors. And so for youth that had reported that they had only had sexual experiences with the opposite sex, 20% had illicit drug use, whereas anyone who had ever reported any same-sex partners reported 39% risk of illicit drug use. And then if we kind of walk through the three other behaviors that they talked about, looking at vaping in the last 30 days, using marijuana, or drinking alcohol, you can see that being an LGBTQ youth increased the risk of those behaviors, and having any sexual partners that were the same sex also maintain that same trend of being much higher. This final spoke of the wheel we're going to talk about is mental health. And for me as a hospitalist, this is the biggest reason that I see LGBTQ youth. And so if we look over on the right-hand side, we'll walk through some of the most common things that they report. This data is also from the Trevor Project and the report in 2022. On the left-hand side, you can see the data starting in 2020, and then on the right-hand side going all the way to 2022. And so we'll start at the top of this. That orange bar represents symptoms of anxiety. And so you can see that over the last 3 years that were reported, about 70% of LGBTQ youth report symptoms of anxiety. Walking down from there, you see the yellow graph, and that is symptoms of depression. And so you can see that hovering around 60% of these youth are reporting symptoms of depression. For me, one of the most kind of startling and remarkable pieces of data is what we come to with our next graph that's like a purplish blue. If you look at that graph, the question that the youth were asked was, within the last year, had you seriously considered attempting suicide? And you can see that in this graph, it hovers around 40%, was up as high as 45% in 2022. If you look more specifically at a subset of LGBTQ youth and look at transgender youth, their rates of seriously considering a suicide attempt within the last year get closer to 50%, so 1 in 2. And so we have a huge opportunity here to be able to intervene, support, and mitigate some of the risks for this population. And then on the very bottom, in the grayish green, you can see our final set of data, and this is actually youth who had attempted suicide. And so you can see that it hovers around 15%, reaching 14% in 2022. And so if we think about that's more than 1 in 10 LGBTQ youth who's actually attempted suicide. So I think in terms of thinking through this, we know that transgender, non-binary, and ethnic minority youths are at higher risk. We also know that youth subjected to conversion therapy are also at higher risk for these symptoms, and also in terms of suicide risk. And just to give people a little bit of background and thinking about, how does this compare to cisgender youth? The rates in terms of seriously considered suicide are at about 33%.
So I think all of those disparities are really powerful. And then when you add to those sort of this next slide in the data here, which shows that in general, there's a lack of comfort with medical providers with our sexual minority and transgender youth. There was two studies of lesbian, gay, and bisexual young adults and high schoolers that shows that between 2/3 and 3/4 of these youth had not disclosed their sexual orientation to their healthcare provider. And this was really in stark contrast to the fact that these same respondents, 70% of them had come out to their parents, their relatives, and friends. When they delved a little bit deeper, it looked like most of them were not asked by their provider, and interestingly would have liked to have been asked about it, but weren't. I think the data is even more concerning as we get to our transgender patients. According to a survey of more than 27,000 transgender patients, 1/3 of them had had at least one negative healthcare experience in the past 12 months. Nearly a quarter actually avoided care due to fear of mistreatment. And then 2/3 hadn't revealed their transgender status to their medical providers. So really, again, an opportunity here as we work on building trust and creating these environments. There was a systematic review in 2021 that looked at what some of the barriers were specifically for our transgender individuals. And these were some of the reasons that they listed. They expressed feeling targeted for transphobia. So participants expressed that they were scared or even petrified to enter healthcare spaces. They talked about concerns of having their gender identity either dismissed or even mocked by other patients and also by staff. They expressed feeling stripped of their personal dignity. They described clinicians who asked irrelevant questions about their transgender status, who performed unnecessary medical examinations, or who they felt exhibited them as a case study to another physician. They also expressed feeling invalidated by misgendering, which they felt reflected disrespect as well as doubt about their gender identity. I thought it was also interesting that they talked about feeling burdened by the need to educate their providers. So some of them were angry that their physicians didn't know about transgender health. And then others actually expressed that they were afraid of being harmed because of their provider's ignorance. And then finally, fear of being outed by anatomic exposure. So the people expressed fear of having to reveal parts of their bodies that either they disliked or that they didn't want to acknowledge during the course of the medical examination. So I think these are all things that are important that we keep in mind as we move forward and care for these patients.
So I wanted to take a little bit of time. We've talked about a lot of the negative impacts, but I think one of the other things for us to acknowledge is what positive impact we can have for this population. And so before we get into kind of more clinically focused information, I wanted to talk a little bit about what we see in data for youth that have more protective environments. So this data relates to the data that I shared before, and it's looking again at LGBTQ youth who had attempted suicide in the past year. And this looks at whether their home environment and their school environment was affirming or non-affirming. You can see on the left-hand side on our first box, home on the left and school on the right. The orange bar is people who identified that their home and school environment was not affirming. And so you can see the risk for attempting suicide was 16% for a non-affirming home and 17% for a non-affirming school. If we contrast that to people who had identified that they had an affirming environment at home, that decreased the risk of suicide to 10% and decreased the risk of suicide attempts at school to 13%. So a significant impact. We see on the right-hand side, as I'd mentioned, our transgender and non-binary youth are at even higher risk of attempting suicide. And so you can see again at home, if they were not in an affirming home, their risk was 20%. That decreased down to 14% if they were in an affirming home. And then on the right-hand side, if they were not in a gender affirming school, it was 21%. And then if it was an affirming school, that decreased down to 18%. And so I think, these youth, similar to us who spend most of our lives at work, a large percentage of these students' time is spent at school. And then obviously we know in terms of outcomes for youth, one of the most crucial things is their home environment. So being in these environments and having them be affirming makes a huge difference in their health and well-being. So looking more specifically at what we do in the clinical settings, these reference a few studies that show that patients have better outcomes if they are treated in environments that are affirming. So provider-supported medical and social transition associated with lower rates of anxiety and depression. The patients themselves improved better mood, cognitive functioning, emotional stability, and overall well-being with provider support. And so we really have a huge responsibility to provide safe spaces for routine medical care, screening, and resource provision. I think about this, I think we can all think of situations where either ourselves, a family member, or a patient may have avoided medical care. I think for all of us, it can be really difficult, even being in the medical field, to present for things that may have sensitivity, things that maybe culturally there may be a lot of stress around, or even some shame. And so we're asking a lot of our patients to just show up in these spaces at all. And so making sure that they're respected as a whole person when they show up in these spaces is crucial.
I think the other thing that comes to mind as I listen to the risk, especially for our patients who are in non-affirming environments, is that it's our chance to screen them as well and consider higher risk status in our patients who we hear from them that their home or their school setting is not affirming. And then switching gears a little bit, our final big picture reason for creating affirming environments is that there's a large LGBTQ population all around us. So as I mentioned before, it can be really difficult to quantify. As we look at estimates for the LGBTQ population of the US in general, the range is pretty broad, anywhere I found from 1.7% of the population to 5.6% of the population. If you take sort of a middle of the road estimate, so 3.5 was what one of the studies showed of the total US population, that equates to about 9 million people, which is roughly the population of the state of New Jersey. So again, I think as we're thinking about this is, definitely a minority group, but it is sizable, and it's important that we consider it in our care. And then here in California, I think the estimates are even higher, more than 5% of the general population. And nearly a quarter of LGBTQ individuals will have children. So those of us who practice in the pediatric space have the opportunity to be treating not just patients who are LGBTQ, but also patients with parents who are LGBTQ, as well as, thinking of our colleagues, of our research subjects, of our coworkers. And so I think that there's a reason for us to really invest in these safe and positive spaces in the healthcare setting.
Yeah, and I think while we're focused today on our LGBTQ youth, we know by making the general environment affirming, it's crucial. The Human Rights Campaign had done a report in 2018 called A Workplace Divided. And in that report, they said that 46% of LGBTQ plus workers say that they were closeted at work. In addition to that, when they asked non-LGBTQ workers if they knew of any employees at work that were open about being LGBTQ, 50% of them said that they didn't know of any employees that were LGBTQ. And so we know from looking at the data that there are people in these spaces who are showing up and making an overall affirming environment, and making sure that our colleagues also feel safe and that they can show up as them whole selves is really important in terms of, I think, our well-being also as staff when we think about burnout and all the other things that we've been through recently with the pandemic. Making sure that, again, everybody can show up to work and be who they are is crucial.
As we move on to the next part of our presentation, I wanted to just spend one quick slide and talk about the difference between a gender affirming environment and gender affirming care. I feel like we're hearing a lot about gender affirming care, particularly in the news recently with certain states' laws that are affecting this for our patients. So gender affirming care specifically refers to the healthcare that's provided in the gender transition process. So things like social transition, specific mental health resources, prescribing medications, or for our older teens or adults, referring patients for gender affirming surgeries. And many of us in our roles will never participate in the medical care that's directly involved with the transition process. But I think that every one of us can focus on learning how to create a gender affirming space, with the goal of making patients feel safe and welcome in the healthcare setting. And again, I think our goal in this is that we want our patients to feel safe so that they keep returning for the care that they need.
So the next thing that we wanted to do was share part of this video. Obviously, we've shared a lot of data and information, but we really wanted to use this opportunity to share this so that we could share what the lived experiences of some of our gender diverse youth in the healthcare setting. So we'll listen to this. It's about a 3-minute video, and again, give us a flavor of what these experiences have been like.
You don't know what we're going through, and a lot goes on in our heads because we have to deal with the world accepting us being transgender, and health is something that is a big concern with us.
I think for me, one of the biggest problems I encounter is that whenever I go to the doctor, I end up telling the doctor more about my body than the doctor tells me, because they just don't really understand stuff or understand how things work, which I get, but also it's kind of their job to know. And I feel like, and I know that like hospitals are supposed to provide training for them and stuff like that, but they don't. And so it ends up being, because trans people's bodies and what they're experiencing and what cis people go through are totally different in a lot of ways, but in a lot of ways they're not, and they don't really know where that is, and what kind of boundaries those things have. And it just gets really weird sometimes.
Can you just talk a little bit about what it feels like to sit in the lobby?
After you done signed in, and especially like me, I don't have my name changed legally done just yet. My gender marker is not legally changed either. So it's kind of hard for me to have to sign in and, give up all my documents and stuff like that. And whatnot, I retrieve them back and then wait patiently for the doctor or somebody to call you out. And then you're just waiting on that door to open, and you're just like, oh God, what are they gonna say? What are they gonna say? How are you gonna do this? And then when they call your name out, you kind of don't want to just sit there, because then they're gonna look at you and be like, hey, they just called you. No, they didn't. No, they didn't. No, they didn't. Wrong person.
I just wish that their kindness extended to trying to find a level of understanding with their trans patients that I just don't think exists for a lot of doctors. Because it's so amazing and frustrating to see those wonderful intentions and then just still leave really upset.
Yeah, a trans-friendly doctor's office would be people who are culturally competent, people who actually, I feel like if you don't have a desire to be affirming of different identities, then don't be a healthcare worker.
Statistically, you're going to have quite a few trans people entering into your office. So that's a lot more common than your very, very rare disease that you might spend a month studying at your medical school. So it's not just this, one tiny segment. If you can learn and study about a very rare disease, that you can also learn and study how to be respectful and polite to trans people when they come in.
Now is more of a time than anything to want to get on the bandwagon of trans healthcare. Because it is happening, it is out there, and more folks are coming out, not necessarily at, 30, 40 years old, even 20, consensual, I was to say. If people are coming out younger and younger, I am Jazz, is 7 years old. And when you actually take the time out to really focus on, what your client or what your patient's, needs are, and you really have that, oh, okay, I can do this, because it's not really that hard, it's not that difficult. Or even if it is something difficult, challenge yourself. Challenge the medical system. Challenge the healthcare field. Do it. Because what's the worst they're gonna tell you? No.
So if you want to hear more in terms of those voices, as you guys saw, that was from the University of Michigan, and they have a lot of other great information. And I think, again, it's really powerful to hear individuals' voices in terms of what their experiences are and what they need from healthcare providers. Now we're going to focus on 9 key affirming practices to create a affirming healthcare environment for patients who are gender diverse. So the first one is ask, do not assume. I think this is, as we'll talk about, one of the biggest ones that people make mistakes in is a patient's appearance may not reflect their gender identity. The only way to know a patient's gender identity, name, and pronouns is by asking respectfully. I will add to that oftentimes in terms of how I interact with youth, I don't necessarily ask them when they're in with a caregiver or things like that. But what I'll often do is open the door for them to share that by introducing myself. So I'm Dr. McKnight. My pronouns are she, her. What should I call you? And then they have an opportunity, if they feel comfortable, to be able to share that with me. The second affirming practice is to understand that trauma can be invisible. The medical community has historically mistreated people who are gender diverse. The historical trauma can have widespread effects and requires a trauma-informed approach. And I think, unfortunately, with our sexual and gender minority youth, as well as people get into adulthood, most people will be able to describe an experience that was fairly traumatic for them in terms of people not being sure what language to use or how to handle sensitive exams or other experiences. Next, we've touched on this a few times, and the video that we just watched touched on this. Let patients be patients. So healthcare professionals must educate themselves about transgender medicine instead of relying on patient knowledge. Certainly not all of us are going to be experts on gender affirming care, but we can learn how to use basic knowledge in terms of things like, instead of saying breast, being able to say chest, instead of being able to say women, saying people with a uterus, and being able to start to shift some of our language and the things that we're saying so that we're more inclusive and that we're sensitive to our gender diverse population.
The next practice includes focusing on the individual. So gender can certainly be an important part of medicine, especially depending on what the patient is presenting for. But obviously, it's only one aspect of a patient's or a person's identity. And so I think we need to be careful not to let it distract us or detract from doing a full and appropriate medical evaluation for whatever they're being seen for.
Yeah, and I think one of the things that people sometimes will report is similarly, like, we all like to avoid things that make us uncomfortable. And so, like, are we making sure that we do a full workup for a patient who may be a transgender boy, but has a uterus? And so, I think, again, we may have a higher threshold to be willing to engage and do some of the appropriate exam that we may not have the same hesitancy in a cisgender patient who appears.
The next practice is to involve the whole village. I think that's part of the reason I'm so excited to be participating in this session and to have you all here. Really, all of our members of the healthcare team need to be committed to creating an environment that's affirming. So I think as we see these patients in the clinical setting, we're hoping that we can provide some practices that are helpful to you, and then also maybe that you incorporating them will be encouraging to your coworkers to do the same.
Yeah, I think when you look at how many different people, especially in the hospital environment, the patients interact with, the number, when we've had to do infection prevention stuff, the number is enormous. And so just thinking about, like you're saying, modeling that and making sure that all of our staff get the resources and the education to be able to do that.
And unfortunately, I think that each of those touches is also a potential for error, for trauma. And so I really think the responsibility is on us as a health system to just incorporate this into our culture and to get it right as much as we possibly can. And so this actually kind of plays into this next one, is to let the walls do the talking. So our physical setting, I think, can really help set the tone for what our patients expect. So things like flyers or signs or pamphlets or audio or visual displays are all conveying information to our patients and their families. And so I think being very aware that these messages need to use gender affirming language and graphics, and thinking about them from that lens as they're being developed, or as you see existing platforms already around, they need to be updated or changed so that they're appropriately affirming.
The next key point is to work to change the system. The system is not designed for patients who are gender diverse. Affirming providers often have to develop workaround solutions when problems arise with forms and electronic medical records. I think many people have a bias in terms of perspective of assuming, again, people are cisgender as well as heterosexual. And so if you start to look, I know we've made a lot of efforts at UC Davis, but there's still a lot of opportunity to think through what kind of language are we using and what does that communicate to somebody in terms of how included they are in our patient population. The next one is respect patient privacy. So sex assigned at birth, gender identity, and transition history are HIPAA protected and should be only discussed in private when medically relevant. Dr. Zimanatos mentioned this earlier, but many transgender or gender diverse patients will also describe experiences where perhaps they came in with a cellulitis and people begin to ask them questions that may be focused on their gender identity, and unfortunately feel like really it's being treated with curiosity and instead of being medically relevant. And so just making sure, again, that we all are focusing on what's medically relevant, respect the identity of the person, while also not asking unnecessary questions. And then the last one, and this is probably one of my favorite things that I've ever heard in terms of being transgender. So honor each person's experience. There's no one way to be transgender. And I think this is really crucial into understanding that everybody's journey is a little bit different. People have a different experience in terms of what their journey is in terms of social transition, legal transition, what they do medically in terms of whether they end up taking any hormone blockers or any other treatments, and then whether or not they have a surgical transition. And so each patient's goals are going to be different for their transition, and there's no right or wrong way to transition.
And I think in a way, this can also circle back to that ask, do not assume, because I think, honoring their experience really reminds us that, like you said, because everyone's experience is different, the endpoints we shouldn't assume are going to be binary or going to be what we expect. And so making sure that we sort of understand where the patient's goal is and doing our best to help them to reach that.
So now we're going to transition a little bit in terms of what do we do, what is misgendering and why it happens, because I think this is one of the most common negative experiences that our gender diverse patients have. So misgendering occurs when you intentionally, or for many of us often unintentionally, refer to a person, relate to the person, or use language to describe a person that doesn't align with their affirmed gender. It may occur inadvertently when someone's physical characteristics suggest a particular gender. It might occur when the gender listed on someone's ID doesn't match their affirmed gender. It could occur deliberately in an effort to harass or bully a patient, or it may just be a mistake. I wanted to share, again, a lived experience and perspective in these quotes. The first person had described, being misgendered makes me feel small and weak. It feels degrading, worthless in a way. And then this other one is a long quote, but I think it really helps us to understand, for us as an individual, we may be showing up with that patient and have one limited experience, but they may be having multiple experiences that are negative. So day after day, drop after drop, it builds up. A single instance on its own is no big deal. A few drops, not a problem. But when you are restrained, when you cannot escape the drops, when it is unending, those drops can be agony. People aren't sensitive because they can't take a joke, because they can't take being misgendered one time, because they lack a thick skin. People are sensitive because the drops are unending and they have no escape from them. And I think, again, like when we think, when I see a patient in the hospital, no one's in the hospital who's not stressed and having some significant health challenge. And so you take someone who's already pretty vulnerable and taxed, and then add another layer onto that. So something that I think, again, if we can do this right, it can make a huge difference in terms of that patient's experience. So we're going to talk through a framework that you can use to course correct in the event that you misgender. And so the TACO framework stands for thanks, apologize, correction, and onward. And so when you face a situation where you, or maybe even another staff member misgenders someone, you want to give thanks for the correction when the patient or a family member or caregiver points that out to you, and demonstrate sincerity in that. You next want to apologize briefly and succinctly. You want to keep it short, don't dwell on the moment, and don't shift the focus to you. We'll talk about this a few times, but a lot of our tendency is to kind of self-focus or feel so embarrassed or bad that we really kind of dwell on our own feelings about it, rather than centering the person in front of us and that patient, and making sure that while we acknowledge that apology, but that we actually continue to move on and meet that medical need that they have. So the next piece helps us to do that. So provide a brief correction, say the same statement again with the correct name and pronouns. And then the final one, keep moving onward. So continue with the original conversation and go back to the point of the clinical encounter. So now we're going to go through a specific example that gives us the details of this. So a physician goes into the room and says, Chloe reported that she developed shortness of breath overnight. Chloe's parent interrupts and says, Chloe actually uses they, them pronouns. And so a model of this would be, thank you for your correction. I apologize for my mistake. Chloe reported that they developed shortness of breath overnight. A chest x-ray showed evidence of pneumonia and they were started on ampicillin. And I imagine that some of you may be sitting here listening, and I know for me, when I first really worked on starting to get really comfortable in terms of using they, them pronouns and those things, I really had to practice. And so the other thing that I would encourage people is, you know, the only way that this is going to come out more naturally for you is to actually implement it, and to do it in a situation where there's less stress, and just practice these exact words. And so that when you're in that moment and super stressed and feel bad, you have the language and the tools to be able to take that next step in terms of kind of what approach to take, and then also the more comfort in terms of the language that you're using.
I think I've noticed that one of the places that I've been able to practice this process is when we are discussing physician or healthcare provider to healthcare provider. So giving sign out, for example, in the emergency department on a patient and sort of describing their care. And it's not infrequent that someone in the room will realize that whoever is speaking is using an incorrect pronoun, and so correct them. And so I think in a way that's a safer place for us to practice, because we can do that, you know, so that the patient isn't affected by it, but we get to go through that process. A couple of things to keep in mind as we use the taco process, or really any process as we're sort of recovering from a misstep. The biggest thing I think is to not get defensive. This isn't about us. This is about what is happening to the patient and how to make that right. We really need to listen to what the other person is saying. We need to make sure that they feel heard. And I think we need to agree that they know that we know that there's a problem that needs to be addressed. So what we're doing there is acknowledging the impact that our comment or our action had, and validating their pain and frustration. I think this is where we need to remember the difference between our intent and the impact that is happening on the patient. And, you know, making it about us is really making it about our intent, whereas making it about the patient is realizing the impact. And again, sort of moving forward, we don't need to dwell on it in the present moment. I think you can consider following up if it seems like that would be appropriate and helpful to the patient. But really the key there is that it should be that you're doing that because you think the patient needs it, and not because, you know, that we as a person who made the mistake needs that validation. Just a couple other do's and don'ts that we'll just kind of breeze through in that for the sake of time. But again, just sort of a reminder that saying that I'm sorry that I made that mistake, but I didn't mean any harm by it, isn't helpful to anyone. So I think that we don't want to make the process about us, and we don't want to overdo the apology. We want to, you know, again, sort of acknowledge it, correct it, and move on. And then I think this last point is probably the most important one to me on this slide, which is really that we're not going to get this right every time. I think we need to be humble, and we also need to give ourselves and our colleagues grace, and just realize that with practice, we will get better and better at this. And so we just need to keep working at it. So I think this is one of those that the practice sounds pretty straightforward, right? Like I can remember a mnemonic and remember the things I'm supposed to do. but life is never quite as easy as the scenarios that come up on our presentation. So I think, kind of thinking about, are there barriers to using this framework or challenges that we think about as we're adapting them in our clinical setting?
Yeah, I think for me, probably truthfully, the biggest barrier is having practiced enough that it comes more naturally. Because honestly, you said you can remember mnemonics. I'm not as good at that in the moment. I think for me in that moment, I tend to get flooded and and stressed. And so for me, I've really had to deliberately keep working at doing it. And I think the other piece is oftentimes we may be pointing out something that, makes us uncomfortable or someone else uncomfortable. And I still, I think I'm continuing to practice in terms of also correcting somebody else that may be on the medical team. Sometimes work with a lot of people that we may not know very well. So we also don't know how people are going to respond. So I think for me, it's had to be working to increase my confidence in terms of navigating this on behalf of the patient and doing those things.
Yeah, I think similar for me, it's sort of having that multiple individuals involved in the process. In academic medicine, we frequently sort of work in groups, and so we'll have students or resident trainees with us. And a lot of times, as the attending, we are the most knowledgeable person in the room about the medical issue, but that doesn't mean that we are the most facile at affirming the patient or sort of using the correct language in a situation. And so I think that sort of being sure that we're maintaining our humility and sort of being willing to be corrected by anyone in the room. And in a way, it's also, I think a really powerful chance for us to model how to sort of hopefully gracefully correct a misstep so that we, are minimizing the damage from that.
So to summarize, we wanted to go through the 6 final tips in terms of using inclusive language. So use a non-judgmental tone and body language. As we've discussed, don't make assumptions about gender identity or sexual orientation or health behaviors. Avoid gendered language. So sir, ma'am, young man, young lady, boy, girl. Use the patient's chosen name and pronouns at all times. That's been a big one. I've had experiences where the medical team uses the name and pronouns in front of the patient, but then in the workroom, people may slip into misgendering the patient. And so it's really important in terms of honoring that patient, as well as for us to do our best to respect that patient, to make sure that we're using it in all settings, even when the patient isn't present. If you make a mistake, offer a sincere and brief apology, and then welcome the feedback from the patients.
All right, so moving on from misgendering to some of the other challenges that we can face in the clinical setting, we wanted to use a couple of case scenarios to kind of highlight these. And so the first one is the case of Philip, who is a 17-year-old transgender male who comes to the emergency department with chest pain. His history has been doing a lot of weightlifting, especially recently, and the pain started right after his most recent intense workout. He's currently taking testosterone therapy, but isn't on any other medications. And as you're getting your history, it really sounds very much like he has costochondritis, but obviously we don't want to jump to any conclusions. And as Dr. McKnight mentioned, this is one where we don't want to shy away from doing an appropriate and thorough medical examination. And so we want to do a good physical examination and also obtain an EKG to assess the chest pain before we make any diagnoses. But this is certainly an exam that can be challenging and importantly can be anxiety provoking. So I think thinking about which portions of this are going to be the most difficult for Philip. So thinking about the physical examination of his chest, of having to undress for the EKG and have to sort of engage with healthcare providers with sort of, again, sort of stripped of some of the gender identity items that have been helpful. And so the next steps are kind of, how do we do that? So how can we obtain an EKG without triggering him? I think one of the probably key features here is just to ask permission before we do anything. So, sort of being very clear about what we need to do, why we need to do it, and then again, getting permission so that we aren't moving forward with tasks without his consent. I think ensuring privacy as much as we possibly can. So making sure that all non-essential members of the team leave the room and that it's really only the people that need to be there for the exam that are there. And then maybe not in this case, but maybe in cases of more invasive procedures. So thinking about potentially a pelvic exam in a patient, you could think about whether anti-anxiety medications would be appropriate as you're kind of gauging their response and how this situation is affecting them. I think in general, it helps me to think kind of proactively about what points of contacts might be a negative influence for this patient or for their family. And I think, Heather, you touched on some of these too, but for me, it happens frequently when I have to discuss or examine sort of healthcare issues that are non-concordant with the patient's gender. So documentation of a negative pregnancy test, if we need that for a radiology study, talking to a family about that in a trans male can be difficult, or timing of a last menstrual period, things like that. And so I think that being aware of them ahead of time can be a big step, so that I'm more nothing like a little technological challenge in the middle.
Do you want to
Can you
share?
hear me?
Yeah, I can. Do you want to share instead?
Nope, because my Wi-Fi on my computer is still totally out, but I'm on my phone. So
Sounds good. I'm on my hotspot. So this is a new experience for us. So I am not sure where you're at, Leah, if you'd finished out that case.
yep, I think I was just about done with it, and especially in the interest of time, I think moving on makes sense.
Okay, so case scenario number 2 is a 15-year-old who presents to the hospital with suicidal ideation. While dad is in the room, he refers to the patient as Sally, my daughter. However, when you interview the patient alone, you find the patient identifies as a boy with the preferred pronouns he, they. He goes by Sam at school. Family is not aware. And so this is definitely a situation that we face at times. And so thinking through, how do you navigate further discussions with family in front of the patient? In particular, what pronoun and name do you use in front of his family? So similarly, in terms of explaining things to the patient and asking permission or what they're comfortable with is the same approach that I would use in terms of do they want to continue to keep it private, depending on where the patient's at. Similar to some other difficult topics, we may offer to support them in talking to their family if that would be helpful. But for many youth, they're not yet ready to disclose this information to family or caregivers. How do you approach notes? What pronouns do you use? You have to be really thoughtful and careful about that in terms of what caregivers may have access to. So typically, if a child is not willing to share it with their family or able to, then I would not include that in the medical record, or only include it in places that couldn't be disclosed to a guardian. And then what about the rest of the medical team? How do you ensure everyone is affirming to the patient without outing the patient? This is a little bit more challenging when they don't want that information in the EMR. And so oftentimes what we'll do, at least on the inpatient setting, is that we'll put it as a note in our sign out to each other that is not part of the medical record.
And so I think it's actually helpful to be able to have this information in our electronic health records, and actually all certified electronic health records are required to have the capacity to record sexual orientation and gender identity data. But it doesn't mean that it's straightforward, and it also doesn't mean that all organizations are actually actively using the functionality that is available to them. But when we do use it, we want to make sure that we obtain consent from the patient before putting it into the EHR, and also making sure that they know who will be able to access it there. And then, as you said, Heather, I think making sure that we ask the patient what name and pronoun they want to use in front of family, or what name and pronoun in front of staff, especially if it's different. And then for our adolescents, we're confirming sexual orientation and gender identity information at each admission to the hospital. And then remembering that our patient's information might not fit into the checkboxes in the EHR. So knowing where we can enter free text when necessary, so that we're not sort of mislabeling patients because we can't find the right box to use.
So barriers to collecting sexual orientation and gender identity information is that not all patients, as we discussed, are out to parents and guardians, and they may not accept the patient's identity. Not all patients want to be out in the EHR. For many patients, they go through a fairly, difficult transition initially in terms of trying to navigate everything that they're navigating socially in their family, at school. And so just again, being really sensitive to what that particular patient's needs are. Sometimes parents and children don't agree with how they want things in the medical record. We have less of this challenge at UC Davis specifically, but a lot of medical records are still lagging behind in terms of being able to incorporate the data or how the information is displayed so that people can most effectively use it. And then often, people may not be as comfortable trying to obtain this information. So again, we need to train our medical staff so that we are using language that's inclusive and that allows us to be able to determine someone's identity and appropriately address them. So now we're going to look at how do we change from looking at our gaps to taking some action. And so we're going to share with you a checklist, and you'll be able to scan a QR code that lets you see the entire checklist. I'll let you know this checklist is very extensive, and the goal really isn't to overwhelm people, but to give people a few places to start. And so I would encourage everybody, as you look through this list, and we'll walk through it a little bit, to select 3 priority items that you'd like to work on after this session. And then feel free to share in the chat the items that you've chosen.
So this worksheet is available on that QR code on the right-hand side. It's going to be the same QR code for the next 3 slides, and it gives you access to the entire worksheet. We have it split up here based on sort of the 3 different settings where we are inviting people to make some concrete changes. So this first one is looking at things that address our personal practices. So these are things like making our own pronouns more visible. So thinking about pins or badge buddies or our email signatures or our Zoom logins. Things like including pronouns in our introductions to patients, asking our patients or colleagues or even new acquaintances what their name and pronouns are and how they'd like to be used. We talked a little bit about sort of, letting the walls do the walking and creating a setting. So maybe looking for lanyards or badges or things that we can make visible for our support of the LGBT community. Avoiding gender specific language ourselves. Thinking about the HEADS assessment for those of us that do social histories in adolescence and sort of how we're asking teens about their gender identity or their sex assigned at birth or their sexual orientation, and maybe trying to incorporate some very sort of universal practices and how we can get better at that. Of asking and documenting family structures for all of our patients is important. And this is especially important so that our patients with diverse family structures, such as same-sex parents, don't face awkward situations because things have been assumed along the way. And then at the end, we'll show you some additional resources, but there's some opportunities for self-education. So resources to better understand the experiences of our sexual and gender minority patients. So this next part of the worksheet is thinking about how we can incorporate these changes into our clinical setting, into our teaching or our research environment. And again, you'll be able to have access to this, but in general, we can think about, at work, are we making an effort to create safe spaces for our LGBTQ patients, but also for, our students, for our staff, for our colleagues, even things like being aware of and being a resource for all gender restrooms or for all gender call rooms. We can think about incorporating teaching into our trainee curriculum or into faculty development, or including content as it relates to patient care if we're educating our trainees as well. And then for those of us that do research, thinking about study design or implementation, including things like including gender variations or pronouns into the data elements that we collect in our research studies, or even doing research specific to the LGBTQ needs in our community. And then fortunately, it's not an issue here at UC Davis, but depending on people's employers, you can advocate at your employer for including things like sexual orientation and gender identity and expression into a non-discrimination policy. You can also advocate for participating in the Human Rights Commission Healthcare Equity Index. Things like intentionally including images of gender diverse individuals and families in our clinical spaces, in websites, in educational presentations or materials or handouts. And then for those who are formal training, there is ally training available through the Trevor Project, and also a Safe Zone training curriculum, which is available free online as well. And then finally, the last part of the worksheet is how to get involved in our community. And this is things like learning about local support or therapy groups, as well as national resources for our youth, as well as for their families and caregivers, increasing our own knowledge, familiarizing ourselves with some of the non-medical interventions. And again, I think this carries over into our professional lives as well as healthcare providers. Learning about and fighting misinformation, especially about gender affirming hormone and surgical therapies, as that's been sort of in the news a lot lately. And then as Dr. McKnight had spoken earlier, because of the overlap with the homeless population, considering partnering with housing and community agencies that specifically address LGBTQ youth homelessness. So that was a whole lot of options that we just presented. And there's a different this next slide that is going to give you a list of resources for how you can sort of individually address some of those. So for the things that you picked as priorities, if you're like, wow, I really want to do that, but maybe you don't know exactly how to go about it, what this is a list of resources that can help with that. I wouldn't suggest just trying to go through and read this. It's a little bit overwhelming, but if you find that, again, sort of there's a practice that you found on the worksheet that you want to do, you can cross-reference it on this list, and it can give you some ideas of resources for making that a little bit more practical.
So in terms of changes in practice, our goal is to provide gender affirming care in environments that mitigate the negative effects of disparities faced by our LGBTQ youth. Using the TACO approach can be implemented in misgendered moments or when someone performs a microaggression to improve patient care and rapport. Committing to personal, professional, and community actions can create and improve affirming environments overall. We wanted, before we closed out, to highlight the many models for gender affirming care. There's some really excellent resources. That first QR code is an entire toolkit on gender affirming pediatric care. In the lower right-hand side, WPATH is considered to be the standard of care in terms of gender affirming care. If you're looking for information in terms of how do we actually take care of children and youth who are gender diverse, and again, combating some of the myths that are out there. And then finally, these are some of the resources that Dr. Zimanatos had already mentioned. There's a QR code for more resources. I'll tell you that if you're looking for some basic information and just general understanding, my two favorites on this list would be the Trevor Project and the Human Rights Campaign. And as Dr. Zimanotos mentioned, they do the Health Equity Index, which UC Davis is part of. And so it gives you information in terms of what does that mean to work for an institution that has met those goals. These are our references. And then we wanted to open it up in case anyone has any questions or comments. And we're going to go ahead and stop recording now.